talk. It will be about updated overall survival data of the CDK4/6 inhibitor plus endocrine therapy in advanced hormonal receptor positive HER2 negative breast cancer. This will be presented by Dr. Gamal Zikri. Dr. Gamal Zikri is beyond any introduction. He's a senior consultant of medical oncology at King Faisal Specialist Hospital, Jeddah. Dr. Jamal, please, the mic is yours. You are mute, Dr. Gamal.
Okay. Is this better, Dr. Samani?
Yes, I can hear you very well, yeah.
Well, thank you very much, Dr. Samani, and thanks to the previous speakers, including Dr. Professor Ahmed Saaduddin. And I made my first slide colorful because the arena of management of advanced breast cancer in real life is so colorful with lots of strategies now of different nature and different outcomes. I'd like to see how I can move the slide. Let's have a look. Yeah, there we go. Of course, I would like to congratulate the organizers for successfully going through at least big part of day one. I would like to thank Dr. Nafisa Abdul Hafid and Dr. Muhammad Al-Ghani for their initiative, and thanks for the invitation. I would like to thank the scientific committee and the international speakers from overseas, and of course my dear colleagues and brothers and sisters and friends, the national speakers. I've been given the task of speaking about survival data of CD4/6 inhibitors in 20 minutes. And for this reason, I can just leave you with this slide and say nothing for another 19 minutes. This slide summarizes all the studies in first line and second line settings with with the progression-free survival and overall survival data when reported. But I have to be seen and heard talking for 20 minutes. And I will skip the mechanism of action because it's becoming very boring now, and I think everybody knows it, and move straight away to just the survival data without mentioning the progression-free survival data. So if we look at MONALEESA-3, which tested the addition of Palbociclib to Fulvestrant in the first and second line setting, because they had both cohorts in the study. And I think it goes without saying, even for the subsequent studies, all of them showed significant improvement in progression-free survival. So I don't need to say that again. So the overall survival in this study showed an improvement in favor of the addition of Fulvestrant for both of these groups of patients with a hazard ratio of 0.72. And maybe for the junior doctors and the fellows who are listening today, usually for the progression-free survival, you're always safe if you quote hazard ratio of 0.5 or 0.55. And in overall survival, you're almost always safe if you quote a hazard ratio of 0.7 or 0.75. So that was for the MONALEESA-3. And as mentioned, it has first line and second line cohorts. And it seems to be the benefit was seen on both groups to more or less equal differential benefit. You can see the hazard ratio in first line setting and second line setting is between 0.7 and 0.73. So that is a good thing. There is an update actually in 2021, ASCO 2021. Actually, it was even published. You can see the difference between both arms keeps getting bigger. And after 5 years, the absolute difference in the rates of being alive is 15%, from 31% to 46%. Here we look at the first line setting. We can see by time, the hazard ratio has even gone down further to 0.64. And in the second line setting, it's 0.78. But I think overall, we can say that ribociclib with fulvestrant in the first and second line setting improves survival in first line and second line setting. MONALISA 7, and I think when MONALISA 7 was first reported, we all got excited because it contained a group of patients, i.e. the premenopausal women. And we all had some that debate on what should we do with these patients. And as you know, the investigators recommended LH-RH agonist with endocrine therapy, either tamoxifen or aromatase inhibitor. Looking at the overall survival, we can see again a hazard ratio of 0.76 in favor of adding ribociclib to the endocrine therapy. That was seen in both cohorts, whether they had a non-steroidal aromatase inhibitor or if they had tamoxifen. The other CDK4/6 inhibitor, which is in this case abemaciclib, was tested in MONARCH 2, and I'm presenting the overall survival data. And as you can see, again, classic, you get a hazard ratio of 0.75 in favor of adding abemaciclib to fulvestrant in the second line setting, of course, previously treated patients, and absolute benefit was about 9.4 months at the point of the median survival. You know, like all studies, they look at subgroup analysis, and it seems to be most, if not all, subgroups have had benefit. And here, a certain subgroup or certain subgroups have been highlighted because of some interesting findings. And if you look here on the right-hand side, the figure representing patients with secondary endocrine resistance, and the hazard ratio seems to be 0.787. And on the left-hand side, patients with primary endocrine resistance having a hazard ratio of 0.686. Now, my interpretation is that both cohorts do benefit in terms of overall survival. And the main reason why I included this study is because of these two curves is because of another study where resistance to endocrine therapy or to previous endocrine therapy have shown some more or less different results. And that is the Paloma 3. So the Paloma 3, the first overall survival data were presented in 2018 or published in 2018. If you look at the total cohort of patients, you know, more or less, probably, I think it's unfair to say there is no improvement in overall survival, but more or less, there is, you know, good separation of the curves. And I think it's quite unfair to just sort of say palbociclib does not improve overall survival. But what they have done, they, similar to the study of abemaciclib, they looked at patients with sensitivity to prior endocrine therapy and those who were resistant to prior endocrine therapy. And they found that the benefit was not shown in patients who were resistant to prior endocrine therapy. But I think it's very important that we remember that these are subgroup analyses. And also the population on the right-hand side, i.e. the endocrine resistant, represents 20%, more or less 20% of the overall population. So this might be an observation that could convince some of our colleagues not to use palbociclib in patients with resistance to prior endocrine therapy, but maybe other colleagues will see it differently. And there was another update in ASCO 2021, very recently, a couple of weeks ago. And they showed that after a very long median follow-up of up to 6 years, the improvement in overall survival continues to be observed. And the p-value is 0.0221. And that was a one-sided p-value. Now, I'm not a statistician, and I don't know if it's too bad to have one-sided p-value compared to two-sided p-values. The 5-year overall survival rates in Paloma 3, as presented a couple of weeks ago, were 23% with palbociclib and 16.8% with the placebo. And they found, or they reported, that every subgroup or all subgroups have had benefit except those with endocrine resistance to previous therapy. And this is just looking at it in a different way. So then intention to treat, you have a healthy p-value, but in the subgroup, those with resistance, and as I said, they represent 20% of the population, there was no benefit. Yet the majority, i.e. those with sensitivity, have had a very healthy improvement in overall survival. And those were actually the randomized big studies, but I think the presentation will be incomplete if we don't include the option of single agent abemaciclib, because I think some of us do use single agent abemaciclib based on the MONARCH or the MONARCH 1 study. And because the MONARCH 1 study have reported survival data as well, I thought I will include the results of the study in the presentation. So they included patients who have progressed on prior endocrine therapy, and patients who have had at least 2 chemotherapy, and one of them should have been in the metastatic setting. And as you can see, it's a phase 2 single-arm study using abemaciclib in those population of patients that I have mentioned. And if you look here, the number of prior endocrine therapies in half of the patients, in about a third of the patients was 1, but actually in about half of the patients, it was, or more than half the patients, it was 2 or more. And if you look at chemotherapy, half the patients had 1 previous chemotherapy in the metastatic setting, but yet another half have had 2 or 3 advanced chemotherapy or in the advanced setting. The response rate was the primary endpoint, and 20% of patients had a response, objective responses. The median overall survival was 22.3%, and I think this is quite interesting in this group of patients who've had relatively lots of prior therapy, and the progression-free survival was 6 months, which is at least relatively exciting. In this study, this is the way of looking at the overall and progression-free survival in a graphical manner, if you want. And they looked at, I mean, it's a self-fulfilling prophecy. They looked at responders and non-responders. So the 20% who responded have had an excellent overall survival. You can see the top red curve. This is amazing survival. So if your patient shows a response to single agent abemaciclib, then you would hope that they will be around for a long time, hopefully doing what they need to do and achieving what they want to achieve with their family members. And what they have done also, the investigators, they looked at the data from MONARCH 1 and compared it to real-life data of patients who received chemotherapy. So they want to see, look, after you give 1 or 2 lines of chemotherapy, should you go to abemaciclib or give chemotherapy? So MONARCH had 132 patients, and they collected 281 patients who have had chemotherapy in the real-life setting, and they have done an excellent matching, and they match 108 patients from the MONARCH with 108 patients from real-life cohort who've had chemotherapy, and they compared them. So basically, we're looking at matched comparison. And as you can see here, in this matched comparison with real-life data, patients who have received chemotherapy did worse than patients who have received abemaciclib in terms of overall survival. So I think this is encouraging that patients who received hormonal therapy and have no good options of further hormonal therapy, it is reasonable to use abemaciclib if the patients have not used CDK4/6 inhibitors in the past. So basically, I'm coming to the summary of my presentation. In the context of overall survival in patients with advanced breast cancer, the use of CDK4/6 inhibitors in the second line, whether that is with ribociclib, abemaciclib, and palbociclib, seems to improve overall survival when combined with endocrine therapy. First line ribociclib improves overall survival when combined with endocrine therapy because of the MONALISA-3, as we have seen. Limited subgroups may or may not have a major improvement in overall survival. How much of that will impact the practice in real life will remain a point of discussion among colleagues. And the final point, single agent abemaciclib seems to be an appropriate single agent oral non-cytotoxic therapy in relatively heavily pre-treated patients and could replace the use of chemotherapy, as we have seen in the matched real-life results. Thank you very much. I'm done.
Thank you, Dr. Jamal. It was really great as usual.
Thank you.
Thank you. Now we'll move for third presentation, treatment of disease progression after first line CDK4/6 inhibitor with Dr. Khair Abu Khair. Dr. Khair, she's well known for all of us. In Arabic, she's علم على رأسه نار. فنتشرف نسمع محاضرتها together.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. السلام عليكم ورحمة الله. First, I would like to thank the organizing committee, Dr. Nafisa and Dr. Mohammed Al-Garni, for inviting me to participate and speak to you today on treatment beyond progression on